So I see it's 7 p.m. So we're gonna start. So welcome to all. I'm very glad that you could join us on this special evening. So first of all, on this World Diabetes Day, the Better team wants to celebrate the incredible strength and resilience of those living with type 1 diabetes. To all of you people living with type 1 diabetes or parents of children living with type 1 diabetes, you are warriors. Your ability to adapt, persevere, and thrive in the face of T1D is nothing short of remarkable. So now, for those who are not familiar with the Better Project, it is a research initiative centered around the Better Registry. This registry is the first of its kind in Canada, focused on individuals living with type 1 diabetes. Participants in the registry share with researchers their daily life data, such as the number of low blood sugar episodes or the technologies they use or their sleep quality, for example. This allows for a better understanding of the challenges associated with type 1 diabetes, If you haven't already done so, I encourage you to sign up to have your voice heard and contribute to advancing research and development of technologies. I have put the link to the Better Registry in the chat if you want to go and check it out. So that's it for my short introduction. Now I want to introduce to you our two presenters for tonight for this special webinar on type 1 diabetes screening. So first of all, we have Maha Lebbar. She holds a master's degree in nutrition from the University of Montreal with research conducted at the Montreal Clinical Research Institute. Originally from France and trained as an endocrinologist, she's particularly passionate about integrating new technologies in T1D management. Her research focuses not only on the impact of these technologies on blood glucose control, but also on the quality of life of individuals living with this condition. Her master's project compared commercial artificial pancreas systems such as Tandem with Control IQ with DIY systems such as Loop in terms of effectiveness, safety, and quality of life. The Better Project also works closely with patient partners living with type 1 diabetes. Tonight, we have with us Darren Davis. He was diagnosed with T1D in 1974. He has been fortunate to have access to world-class care and strong family and social support on this journey with T1D. He dreams of a world without diabetes, and he wants to help bring it about. On the path to that vision, he wants to support initiatives that lead to the better therapies and better lives for people with T1D. So Maha and Darren, welcome. It's very nice to have you with us tonight. So I will let you speak now. It's your turn. I'm going to hide and come back later for the questions period.
Great. Thank you, Nathalie, for this introduction. So I'm Maha, I'm an endocrinologist, and I'm very pleased today to talk to you about screening for type 1 diabetes, the pros and the cons. And for that, I have the help of Mr. Darren Davis, who is a patient partner in the Better Registry. So we can start. So obviously, when you have any questions, you can use the Q&A feature on the Zoom app. And what would we be talking about today? So first, we'll be talking about general information about type 1 diabetes. What is type 1 diabetes screening, the pros and the cons, treatments to delay progression, some screening programs available in Canada, some feedbacks that we will be providing, both me and Darren, and a proposition for a better survey. So let's start a bit about pathophysiology of type 1 diabetes. So type 1 diabetes is an autoimmune diabetes, which means that the insulin-producing pancreatic cells, which are the beta cells, are attacked and destroyed by our own immune system. And we know that insulin is a hormone that helps control the glucose level in the blood by regulating its entry in the cells of our body. And every cell of our body needs this energy source because this is the main energy source for us. And so without glucose and therefore without insulin, we cannot live. So this is a very concerning disease that we need to treat. There are multiple factors that promote the onset of the disease, and those that are well known for now are infection, especially during a young age, genetic background, which is suspected when there's a family history of type 1 diabetes, and the environment and diet. And so the start of the disease the disease doesn't start at the diagnosis of type 1 diabetes. We have a lot of steps before that. And the first step is to be able to determine the genetic risk. There is a genetic risk, a higher genetic risk for type 1 diabetes in those that will develop type 1 diabetes. And so from those people, for a few of them, you will have an immune activations, which means that the beta cells will be attacked by our own immune system. And from a very partial part of them, you will have the emergence of markers that show that there is an immune activation, usually one autoantibody that you have here. And this is what we call the pre-stage 1. And the pre-stage 1 sometimes can lead to stage 1 type 1 diabetes, which is the presence of 2 or more AABs and a normal glycemia, which can go on to stage 2, which you will notice an abnormal level of glycemia and an abnormal level of glycemic parameters, and stage 3, which is the onset of type 1 diabetes as a clinical disease. And so from that, you can gather that the age of the onset of the autoimmune process really precedes by years the age of onset of the disease symptoms. And as you can see in the figure on your left, when we take the levels of AABs in children of people with type 1 diabetes that will later develop type 1 diabetes, you can see that most of them will develop AABs before they're 2 years old. And we also know that the onset of the symptoms usually occur and mostly occurs in adults, as 63% of people that are diagnosed with type 1 diabetes are 20 years old or more, as you can see in this figure here, where you can see in different countries, it is the same situation. Most people that are diagnosed with type 1 diabetes are adults. And this is really a switch of paradigm where we say that it's mostly a children disease. It is not, it is an adult disease as well. And to give you an idea, in Canada, approximately 300,000 people are currently living with type 1 diabetes, which is this is a big number. So what are the chances to have type 1 diabetes when you take one person in the general population? Well, this chance would be 0.4% in the lifetime. And when you take someone that has a first degree relative with type 1 diabetes, this risk is multiplied by 15. But it depends on the type of relationship that you have with this first degree relative. For example, if it's your mother that has type 1 diabetes, you have a 4% lifetime risk to develop type 1 diabetes. If it's your sibling, it's 6%. If it's your father, it's 8%. And if it's your twin, well, it's 33%. You need to keep in mind that most people with type 1 diabetes don't have any relative with type 1 diabetes. So type 1 diabetes occurs in families where there is nobody ever heard of type 1 diabetes. And this is important to be aware of. What are the clinical signs of type 1 diabetes as a clinical disease? Well, you have the frequent urge to urinate, intense thirst, some weight loss, and most concerning nausea, vomiting, and abdominal pain. And you need to keep in mind that those clinical signs appear when you're already at stage 3 type 1 diabetes and do not exist when you're at stage 1, which is when you have the AABs but do not have any abnormal glycemia, and stage 2 when you start to have some really small abnormal glycemia but still not high hyperglycemia that can cause those symptoms. So screening can help find those people that are at stage 1 or stage 2 and that do not have symptoms. And this is one of the major reasons to be interested in this disease is that it has a long-term and short-term consequences. So if we talk about short-term consequences, you have hypoglycemia, which occurs and it's inherent to insulin treatment. Insulin, the objective is to lower your glucose, and sometimes it can go very low, and sometimes you can have severe hypoglycemia with loss of consciousness, etc. On the contrary, you can have hyperglycemia and diabetic ketoacidosis, and this is something that we'll be talking about in the next slides. You can also have a psychological impact of the diagnosis and of the first weeks of diagnosis, where there's a lot of information that are given and a lot of adjustment that needs to be made, and sometimes this could have a negative psychological impact. As for long-term consequences, you can have, with the hyperglycemia and the years that go by, some damages in your large vessels, mainly coronary, carotid, and femoral vessels, but also damages to small vessels in your retina, in your kidneys, and your nerves, and obviously as well a psychological impact due to the burden of the disease, which can be burnout, depression, or anxiety. So for now, when you have stage 3 type 1 diabetes, the only treatment that we have is a substitutive treatment for life, which is insulin. We give the hormone that is missing. And this insulin can be given either by pens or by pumps. So let's talk a bit about screening. What is screening mainly? Well, screening is to be able to detect the disease markers before the disease manifests. And there are two ways to be able to do that. You have testing for autoantibodies, which is the main way we do type 1 diabetes screening because it's easy, because it's available. And you have the second way, which is genetics. And we're going to be able to talk about that later on the slides. And so for autoantibodies, there are mainly markers of ongoing autoimmune process. And you have several ones. You have GAD65, EA2, ZNT8, anti-insulin. And here you have a little picture of a beta cell. And as you can see, those autoantibodies are directed against some receptors in your nucleus here, some elements also in your cytosol inside the beta cells. So you have two ways mainly to detect those antibodies. You can do it by venous blood draw or by capillary assay using kits. You need to keep in mind that some antibodies, especially the GAD65, can temporarily test positive. And this is the case in about a third of people, or sometimes they can experience assay interference, and also in third of cases. And therefore, measuring antibodies needs to be repeated, especially when it's done during childhood. So repeated testing is recommended. One thing that we're sure of, and that the scientific literature showed, is that the more autoantibodies you have, the higher the risk of developing type 1 diabetes. And for instance, when you have one autoantibody that is present, you have 15% chance or risk to develop type 1 diabetes within the 10 next years. And if you have two or more autoantibodies, then you have a 70% risk of developing type 1 diabetes during the 10 next years. And this is a 100% risk if you see a lifetime. So when you have two or more antibodies, you're practically sure to have type 1 diabetes. We just don't know the delay to which you will present the disease, but we're pretty certain that you will get it. And so a vast majority of people with type 1 diabetes have at least one positive autoantibody. Another way of being able to detect the disease before it manifests is genetics. And this is something that we do in research, not so much in the clinical setting. So the objective here, or the outline here, is that certain gene variations are associated with an increased risk of developing type 1 diabetes. And based on this information, we can calculate what we call a genetic risk score. And this risk score is calculated based on the presence of susceptibility variants, so variants that increase the risk to develop type 1 diabetes in over 70 genes. The problem with this genetic is that it's not available in clinical setting, usually not available in clinical setting, and also that it's not representative of everyone, because this score has primarily been calculated and based on a population that is from European ascent and not from other ethnicities. So this is a major drawback for this genetic testing. So at this point of the presentation, you might ask yourself, what is the difference between screening and diagnosis? Well, this is not the same. When we screen, we look for markers indicating the risk of developing the disease. This is a risk assessment, whether it is by antibodies or genetics. However, it remains uncertain if and when the disease will actually manifest, even with the presence of these markers. So this asks the question of, should we be able to provide treatments to delay or cure a disease that we're not sure that it's going to happen? Well, we're pretty sure when we have two or more antibodies, but what about one antibody? And this is very different from the diagnosis. When you have a diagnosis of type 1 diabetes, we are sure that the disease is present. There are glycemic abnormalities. And so substitutive treatment is mandatory. You need treatment and you should not delay the treatment. So let's talk a bit about the pros of screening. Well, one of the major pros for this is to be able to detect the disease before the onset of symptoms, because sometimes the onset of symptoms can be very detrimental, especially when there is a diabetic ketoacidosis. And so as a reminder, diabetic ketoacidosis, so DKA, happens when glucose cannot enter the cells because there's no insulin left. And so the cells use instead fatty acids to produce the energy that they need on a continuous level. And this usage leads to the production of byproducts that are known as ketones and are very toxic for our body. And so we know that, and this is very variable according to the country in which the analysis has been done, but approximately 30 to 50% of children will debut their type 1 diabetes with the DKA. This is a very large number. We also know that a lot of the deaths that occurs during type 1 diabetes in children that are related to type 1 diabetes in childhood are primarily due to DKA. And this is especially the case when we're talking about very small children. Keep in mind, though, that DKA, mortality from DKA is around 1%. So when it happens, it's not that lethal, but still we need to be careful. And I will show you in the next slide another reason why. And some studies have assessed the percentage of occurrence of DKA after screening. So when you take people that have been screened, only 4% of them will develop DKA at the time of type 1 diabetes diagnosis, which means that we can lower the rate of DKA when we screen people. Second main pro of screening is to be able to preserve remaining beta cells. We know that the fact that we have DKA, weight loss, and malnutrition that precedes the diagnosis is something that will impair the remaining beta cells. When you develop type 1 diabetes, you still have some cells that are producing on a very low level, some residual insulin secretion. And this residual insulin secretion is sufficient sometimes to afford a better control of your A1C, of better result of A1C, and fewer long-term complication risk, especially hypoglycemia. And so when you have DKA in weight loss and malnutrition, those cells, they do not survive, and so you don't have this residual insulin secretion left. And so in the figure that you see on your right, you can see that if you take two groups, one group that began its diabetes with the DKA in red here, and the group that did not begin type 1 diabetes with the DKA, for example, someone that has been screened prior, you can see that the HbA1c during a 15-year follow-up is still systematically increased compared to the group of people that did not have DKA at onset of the disease, approximately 1% difference, which is huge. So aside from the fact that there are some confounding factors to those results, it appears in many other studies that it's better not to have a DKA at the onset of the disease and to avoid it, just to be able to preserve the remaining beta cells. Third pro of T1D screening is to be able to avoid confusion with type 2 diabetes. We saw it in earlier slide. Most of type 1 diabetes diagnosis will be made in adult people. And sometimes when it occurs in adulthood, and especially when there are some weight issues, particularly overweight or obese persons, or when you're from certain ethnic groups, sometimes you can get misdiagnosed with type 2 diabetes. And this happens in up to 40% of people that present with a real type 1 diabetes over 30 years old, but are mistakenly diagnosed with type 2 diabetes. And this is something that is really detrimental because we do not give the appropriate treatment, which is insulin, in time. And this is something that can bring up a bit the mortality and morbidity of those people. So screening can help avoid this confusion, because if the antibodies are positive, we're less likely to think, well, we're not going to think it's going to be a T2D, so we're going to put up the treatment real fast for those people. Fourth pro of doing a screening for type 1 diabetes is to be able to participate in clinical trials. And those clinical trials have as objective to develop future treatments aimed at delaying the onset or preventing type 1 diabetes. And if you do not screen, the researchers cannot know that you can participate in those clinical trials. And so there are many clinical trials ongoing, especially in Europe, testing different molecules that I'm not going to be able to read here because it's really difficult at this time of day to be able to read those medications. But there are trials out there that people that have been screened can enroll in to help us understand and find treatments to delay the disease. Fifth and last pro for screening type 1 diabetes is to be able to gradually support the people into the transition into the disease. As you know, type 1 diabetes usually occurs in a trauma setting. You know, you're given the diagnosis, you have 1 week to learn everything. This is something that is very stressful, either for people that are diagnosed and their parents and entourage. So this is something that we want to avoid with type 1 diabetes screening. And so if we screen early on, we can train people into disease management progressively with an appropriate support that is provided either or both by healthcare professionals and peers. And this could ease the person into the disease to be more confident in managing this disease. So after talking about the pros, we're going to be talking about the cons. And one of the major cons of screening that goes against proposing screening of type 1 diabetes is the uncertainty regarding the progression of the disease in individuals who test positive, but also for individuals who test negative. As we saw earlier, false positive results can occur. And so you can be diagnosed at stage 1 type, well, mostly it's pre-stage 1 type 1 diabetes, but it's not the case because there were a mistake in the results, because there were interferences in the analysis, or just because it was a transient positivity. We saw it earlier, okay? And as I just said, positivity may manifest at a later stage. And here, I just wanted to show you in this figure. So you have the 4 antibodies that we usually test for, still on those children that develop type 1 diabetes that have a high genetic risk because of their relatives, one of their relatives that have type 1 diabetes. You can see that still around 2 years old, the autoantibodies appear. But sometimes it can appear later on, especially at 8 years old. So if you test at 2 years old and it's negative, and you don't test again at 8 years old, you can miss those people. And so that's why it is necessary to repeat the testing of autoantibodies during childhood. It is less clear during adulthood, though, because not many studies are done in adulthood, but in children, you need to do the test again. And another source of uncertainty is that we don't know when the disease will onset. Once you are stage 1 type 1 diabetes, which means you have 2 or more antibodies, but no no abnormal glycemia. You don't know how many years, how many months, how many weeks it will take for you to arrive at the stage 2 or stage 3 type 1 diabetes. This is something that we have trouble finding, and there are a lot of studies going on currently to be able to identify people that will progress rapidly versus people that will not progress rapidly. And so, as I said, the repetition of the test, the uncertainty about the timing of the disease onset, and also the lack of access to delaying treatments, because let's face it, those treatments are not available in Canada for now. These situations have a psychological impact that is very important, and that leads to anxiety, to detrimental behaviors such as dietary restrictions and disruptions in family relationships. And some studies have been done in the family of people with type 1 diabetes, and often it's mothers that answer the surveys, but about 2/3 of mothers of children at risk for type 1 diabetes, so children that are at risk but did not develop the disease yet, have adopted a disease prevention strategies. And when I say prevention strategies, these are strategies that are not validated as efficient strategies to delay the disease. And so this can take the form of frequent, often too frequent blood glucose monitoring every day, every hour, or visits, or to be too aware of clinical signs. This can take the form of carbohydrate reduction. And so having this uncertainty can push mothers and families into detrimental behaviors. And the question that we ask ourselves and that we don't have the answer for is, how about this anxiety about knowing the risk? Is it as high as the anxiety when your diagnosis is made? Is it different? We don't have the answer to this question. Third con and last one is the socio-economical impact, whether it is on the personal level or on the society level. So one major question that comes with screening type 1 diabetes is the insurability. Can an insurer refuse coverage or increase premiums if a person tests positive for antibodies? We don't have the answer for that as of yet. Some people can restrict themselves to access certain jobs or opportunities, some lifestyle choices, and for society, is screening cost effective, meaning that is the cost of screening lower than the cost of dealing with the disease once it's onset and have not been discovered before the onset. And this is especially a question to be asked when we're talking about national screening, because in national screening, we'll be screening a lot of people. And so this is gonna top up the costs for eventually 0.4% that will be diagnosed. So this is something that is not very clear for now. So the cost effectiveness is not very clear, at least in Canada. One question that we could ask ourselves is that should there rather be an investment in a national program for recognizing clinical signs of type 1 diabetes? Well, this question has been asked in many countries, well, in a few countries, and some countries it did not, the fact to share information about clinical signs of type 1 diabetes on a general level in medias and such did not decrease significantly the occurrence of DKA, but in other countries it did. So the results are not very clear on that. At the end, who should it be proposed to? Who should we screen? Well, you have two situations. Either you screen first degree relative, which would be the more efficient way of screening because you're more likely to have positive results, right? But you will be missing the majority of people who will develop type 1 diabetes who do not have first degree relative that have type 1 diabetes. The other way of seeing the problem is to screen for the general population. And this is for sure the best way to detect more people that will develop type 1 diabetes, but it is an expensive adventure. So here I just wanted to show you the main conditions in which you should propose screening, whether it is screening for type 1, but screening in general, according to the World Health Organization. And there are conditions to respect in order to propose screening for people. So one of the conditions, well, the first condition is to have a disease that represents a public health problem. And this is something that we can all agree on, right? You need to have a target population. This is something that we can agree on too. The third point is universality, meaning that you have a test of screening, you have a way of screening that is identical and accessible for everyone. And this is something that is a bit unknown in Canada. For example, in Quebec, you only have one AAB that can be done on a clinical practice, and so you cannot do the others, and so you cannot really know the stage of your type 1 diabetes, right? And so universality is not something that is assured in screening for now in Canada. Fourth point is to give the screening needs to allow for detection of the disease before it develops. Well, we have tools with the anti-autobodies when you have at least 2 or more positive AABs, but still we don't have any idea on the timing of the onset of the disease. Fifth point, screening should have a demonstrated medical benefits. There should be demonstrated medical benefits of early detection. And we know that there are benefits when you decrease the level or the incidence of DKA, but the benefits of the treatment, we cannot evaluate that because no available treatment is available here in Canada for now. It should arrive, but still we don't have it yet. So this should be outweighed. 6 points, economical balance. As we talked about, there should be an economic balance between the cost of screening and potential expenses related to the disease. 7 points, the screening test should have an adequate sensitivity and specificity, meaning that the test should detect people that will develop type 1 diabetes. And we saw that sometimes AABs can be falsely positive or can be transiently positive. So this is something that we should work on as well. 8th point, there should be a minimization of potential risks. We saw that the risk of DKA decreases, but what about other risks such as anxiety, stigmatization, insurability, all the things that we talked about? Those are not well studied and should be when we talk about screening. And ninth and last point is to be able to provide informed choices for our patient. And this is something that we work really hard as healthcare professionals to provide. So after hearing all of this, should we take the screening training? And so one way to see it is, no, I just want to walk. I don't want to know my immunological status. And this is okay. And this is right for everyone. So if you decide to screen, well, we can meet at the station and then you screen. One of the cases is that you don't have AABs. So either you repeat the test if we have reasons to believe that the test could could change. For example, if you're a child, then we repeat the test. And if we don't need to, or the repeated test is negative, then you can go walk with the other person. But if you have 1 or more AABs, then you need to get on board of the train. And this is the train that you will be taking. And this train leads systematically to type 1 diabetes, unfortunately, with multiple steps ahead. You have 1 step of monitoring and surveillance of the appearance of other antibodies if only 1 was positive at screening. You have multiple medical and paramedical visits to help identify signs of the disease, gradual education, and support and guidance. You have multiple blood tests as well, glucose tolerance test, HbA1c, fasting blood glucose, and glucose monitoring either by capillary measurements or continuous glucose monitoring. And so the destination is type 1 diabetes. You just don't know how many hours your travel will take. And hopefully in the next 10 years or so, or even less, we will be able to change this destination to a cure with the help of delaying treatments and clinical trials. So what about delaying treatments? We're going to talk about families of delaying treatments. So you have 4 families of treatments. You have the immunomodulatory therapies, which are essentially therapies that will decrease the intensity of the autoimmune process. And mainly you have the teplizumab. I'm sure you heard of it, but you have others as well. A second family of delaying treatment is the beta cell protective therapies, mainly verapamil, which is an anti-hypertension medication initially. Sometimes you can use combination therapies that will work to both immunomodulate and protect the beta cells. And you have one that is really interesting, which is the baricitinib. And finally, an antiviral therapies. Those therapies can work, as we saw in earlier slides, that infections, especially with enterovirus in the earlier years, can lead to the onset of the disease. So those therapies can work at that time. Keep in mind that for now, no treatment is currently available that allows for durable remission of type 1 diabetes. These are all delaying treatments and not cures for type 1 diabetes. Let's talk about screening programs in Canada. And you have two mainly. You have the TrialNet Pathway and Prevention, which is a screening program for relatives of individuals with type 1 diabetes. It concerns multiple countries, including Canada. And the TrialNet team send, upon request, of course, a screening kit to eligible individuals with results that can be given within 4 to 6 weeks. The objective of this group of research is to be able to identify at-risk individuals and offer clinical trials. And as of now, over 250,000 people are participating in this trial, and it has been estimated that 2.5% have at least two AABs positive. Another screening program that is a bit that just happened in the last 2 years, sorry, is the CanScreen T1D, which is a screening program for all Canadians, whether you have a relative with type 1 diabetes or not. And it's funded by the CIHR and Type 1 Diabetes Breakthrough, formerly known as GDRF. This group of research considers the gaps that we talked about on screening, on feasibility, acceptability, and risk among minorities that should be studied and is understudied. So we arrive at the last part of our webinar in which we'll be talking about our feedbacks, and I will start with my point of view as an MD, as an endocrinologist. So I will talk about a woman, a 25-year-old woman that I saw at the end of 2023, whose father has type 1 diabetes, and she wishes to know her immunological status. So I proposed a screening for her, and she screened positive for 2 antibodies. Thankfully, she had normal glycemic markers. So we can all agree that this is stage 1 of type 1 diabetes. And so I programmed biological monitoring for her in the next months, and I gave her information on early warning clinical signs to be aware of. And so I saw her mid-2024. She still did not have any abnormalities in her lab works, but she came up with a lot of questions and a lot of anxiety and insecurities that I did not expect at the beginning. Mainly, there was an anxiety during meals. She always asked herself, will this food raise my blood sugar or not? So there's anxiety around the meals. She also spontaneously reduced her carbohydrate intake. Another aspect of the screening for her is that she developed anxiety about blood tests for monitoring her care. She did not want to have bad news, so she preferred not to do a blood test. I required, well, she did a few, but not all of them. She also delayed her vaccination for the flu because she feared that getting vaccinated will onset the disease. Another aspect is that she became over-listening. She over-listened to her body signals. So, for instance, sometimes she felt thirstier than usual, or she lost a bit of weight. She asked herself, is the disease starting to develop? And finally, she experienced difficulties to envision her future. She wanted to travel, but she delayed it because she was afraid that she will develop the disease while away. She also is reconsidering pregnancy in this condition, in these conditions, and she also do not know if she should disclose her at-risk status to her insurance and to her employer. So these are all the questions that she asked herself that I did not anticipate when I saw her the first time. And this is because in 2023, at least in France, the screening processes were not a discussion at the time. And so everyone just did what they thought was best to do. And I did not have the right education at the time, but now it is there, so I can share it with you. And so now I give the floor to Darren, who will talk about his experience as a father living with type 1 diabetes.
Thank you, Maha. Happy World Diabetes Day, everybody. I think happy is the right adjective there. Happy day anyway. As I think you've heard and you can read, I was diagnosed 50 years ago. I'm going to tell you a little bit about myself, a little bit about my family's journey with screening. When I was diagnosed in 1974, I I took one insulin injection a day. It was a beef or pork derived insulin, so came from a slaughterhouse. And I did urine testing. Uh, and the diet was it was a strict diet. Eat the same thing every day at the same time every day. And then I'd go to my doctor periodically. He'd take blood from my arm and try to figure out how I should adjust my insulin. Um, I started blood testing in the early 80s. I got onto an insulin pump in 1983 when I went into DKA twice over the course of one summer. Um, and I had my first blood glucose monitor in 1985. Today, my treatment has changed a bit. And as you can see on the screen, I've been on an automated insulin delivery system. I said since 2022, it actually might be a little bit earlier, but it's, in the last 3 or 4 years. And there's a sensor on today it's on my hip that gives the same information to my insulin pump that my doctor got once a month or once every 2 months or however often I went. Now, diabetes has been a part of my life, or is a part of my life, excuse me, but it isn't all of it. My parents helped found the Breakthrough T1D chapter in Winnipeg about 40 years ago, and they did it because of me. They did it because they didn't like the future that they were being told about for their child. And so I have the benefit of their activity because research has been a part of my life ever since they did that, because research is so much what Breakthrough T1D is all about. And I have seen some incredible things, some incredible research being talked about, even many of the things that Maha was talking about today, like the fact that there are stages of diabetes, like that wasn't around. Genetics, that wasn't around. No. The types of insulin we use. My insulin doesn't come from a slaughterhouse anymore. It's bacterial byproduct. And it acts so much more reliably and differently than the stuff that I took. I've also seen some promising cures that actually didn't turn out to be so promising, or at least not so promising yet. The one thing I have discovered consistently is that the more we learn about the human body, the more we realize we don't know, and that it's a pretty complicated system. And if we were lab rats or rabbits, we maybe could have cured diabetes several times, but we're not there yet in people. Having said that, the progress we've made absolutely makes me believe that we'll get there. And I firmly believe that a cure for diabetes will be found, and cures actually, because there isn't probably going to be one. I recall at one point in my life, a cure would be not having to prick my fingers to do blood tests. That was a really annoying thing. It was a burden. And well, I have a friend who hasn't done a blood test in 5 years because he's using a sensor that doesn't require it, and he has been for a number of years. So that I tell you that so you know a little bit more about me, and understand the stories maybe a little bit more that I'm going to tell you. So my view is that screening is a personal choice. And I say that it's the same with all treatments for type 1 diabetes. There is no one treatment. The insulin pump that I'm on is great, but I know people who won't use it because it's not aggressive enough for them. It leaves you high too long, and they'd rather control that themselves. I know people who prefer to be not on a pump, but rather to be on a pen. And we should all have all of those options. And I think that screening is just another tool that can be used. Not for me, obviously, I've got it, but for my children ultimately, and for the community at large. So here's my story. I have 3 daughters, smart, active, independent women, and 2 of those 3 have actually been tested or screened. My oldest daughter is adoptive, and she comes from an ethnic community where there's very little type 1 diabetes, and so we haven't had her tested. The other 2, though, as I say, have been tested. And ultimately, for me, the screening has been available. I've heard about it for longer than I've been participating in, let me say. I wanted to know why. What was the benefit? What was the point of doing it? Information in and of itself isn't generally useful. It's what you do with that information that's useful. So knowing I've got antibodies or not, great, but what am I going to do with that? And I think, as we heard from Maha's patient, it can be quite destructive. And so, it has to be thought about. So again, I'll tell you about my kids. So helping find a cure was the reason that we participated and had my daughters tested. My youngest was the first. She was tested at birth as part of a breakthrough T1D study, or partially funded study by Breakthrough T1D, which was looking into the causes of type 1 diabetes, and in particular, whether cow's milk protein was a trigger, an environmental trigger. So she identified as having high genetic risk, so they brought her into the study, and then they tested her on an annual basis every year for the first 10 years of her life. Sometime around the age of 5 or 6, I don't remember exactly, she was showing like 3 or 4 of the autoantibodies. Now, after hearing Maha's presentation, I'm wondering maybe it's not possible, but I don't know. Anyway, she was showing many, way more than 2. And when I first heard the news, I was crestfallen. I felt, oh my gosh, my daughter has diabetes, or is going to have it tomorrow. And I met with a researcher. He phoned my wife and I and asked to meet us for coffee. And he spent a bunch of time talking to us about what this meant. And he probably said a lot of things because we met for quite a while. But my takeaway was that he assured us that Claire might not develop diabetes, that having the markers was not didn't mean that she would necessarily. That the longer she went without being diagnosed, the better off she would be. Now, that was about 15 years ago. And I think we've heard again from Maha even this evening about, maybe that being that, she hadn't been developed yet, so maybe she would be better. Maybe that was a misunderstanding. Maybe that's where the research was at the time. Maybe he was just trying to make me feel good. It worked. My wife and I fretted and we felt sad ultimately, but I was living proof that a life with type 1 diabetes could be a good full life. Now, I also know that that's not true for everybody. I am incredibly fortunate. But there are so many things that can happen in a life that we didn't let it hold us back. We just resolved to wait and see what happened. And we changed nothing in her life. We didn't start keeping her away from chocolate. We just treated her like a kid, like the kid she was, and we just carried on. That's what we resolved to do. In part because we knew that nothing we could do would make any difference. And why have the burdens of diabetes without actually having it? And so, as I say, we changed nothing. She's now 21. She's diabetes free, and she's studying at the University of West Indies in Barbados. And so I feel like she's probably living her best life. My second daughter, we also had tested. She was tested as part of TrialNet. But before we had her, and we tested her for the same reason. It was to participate in research. It was to help advance the cause of finding a cure for type 1 diabetes. She is negative and has always tested negative from what the ages of 8 to 14, 4 or 5 years. She stopped being willing to go for a blood test when she became a teenager, so she hasn't been tested in a number of years. But ironically enough, having no antibodies, she's the one that we actually had a diabetes scare with, where we tested her blood sugar one day because of her behaviors, and her blood sugar was high. And there's only one reason for that, as far as I knew. It was the worst couple of hours of my life while I waited for a doctor to phone me and tell me to wash her hands and test her again. And the reason it was the worst couple of hours of my life was because I saw her living what I had been through. And I didn't want that for her. I'm fine. I'm blasé about it. But for her, I didn't want her to do that. So as we tested, it was all clear. We were so lucky. And And the irony of that, however, strikes me, I guess I'll say. And I think that that's part of the conversation that you have to think about. So here's my thought is, why do you want to know? If you get answer that your child is showing markers or that you're going markers, what are you going to do with that? And I think, as the story about Maha's patient demonstrates, you need to think carefully about that. Is a positive answer going to change your life? Is a negative answer going to change your life? And if you have that change, what are you going to do with it? Now, there is a therapy available if you want to drive south of the border, but it's not available to me, because not just because I'm not going to drive there, but because it costs a fortune. And so for my kids, we chose to let them to do the test because there was a benefit, which was participating in finding the cure, but the possibility of treatment was not there. So let me just finish with a quote from Claire. That's the 21-year-old. Because I asked her, as I was preparing for this, what did it mean to her? And I got a lot of texts back from her, but this one piece I do want to share, because I think it answers the question of what did we as a family do with it. So she said, I didn't think too hard about it, though, in the sense that it didn't alter my life at all. I would just be like, that's a wild possibility, if I would sit and think about it. So what does that mean? Trying to translate 21-year-old into English. I think what it means is that our approach of just carrying on as if nothing had happened, which was something we were able to do. We felt competent and capable to do that. Was also translated to my daughter, and she knows it's a possibility. She doesn't think about it, and we have been able to carry on. And so, should you be screened? Should you get your kids screened? I think it really is a personal choice, and I think you have to be ready for the potential consequences, the upset, the burden. Don't give yourself or your child a diagnosis of diabetes without actually having it. Don't manage. I would say that anyway. But that's a choice that only you can make with your medical team. I'll end there. Happy to answer any questions as well.
Thank you, Darren. This was really very informative, and this helps me talk about the conclusion of today's webinar, and saying that type 1 diabetes, as you saw, begins several years before the appearance of clinical symptoms. And screening for type 1 allows for a gradual introduction into the disease and to help avoid some of the complications that are concerning, such as DKA and their consequences. The impact of type 1 diabetes screening on individuals, particularly in terms of psychological effects, is not well understood and is very variable. As you saw, the experience of my patients versus the experience of Darren's daughter is very different, and we should really look into that. One of the questions that are to be answered is how to be able to do the logistics of monitoring and providing the support, still providing the support, and this is something that still needs to be defined and sorted as for the health institutions. And for now, there is no cure, but there are promising delay in treatments options available. To be available, but this is a new start, and this is something that we're really looking forward. And the main message here, I think, and we can all agree on, is that ultimately it should remain a personal choice for everyone, with an informed choice, of course. And so that concludes the webinar. Thank you very much for listening. I will just maybe talk about this survey that we're conducting, if you would like to answer it. So if you live with type 1 diabetes or have a close family member that has type 1 diabetes, you can answer this survey that is there to gather your opinion on type 1 diabetes screening after everything that you heard. It takes approximately 20 to 30 minutes, and there's a cash prize to win that can be drawn among participants. You have the QR code here. You also have, I think Natalie put it in the discussion box, the link to access this survey. This will help us understand what you feel about screening and to be able to analyze the gaps of screening as well. So thank you very much for your attention, and we're open for questions using the Q&A feature on Zoom.
Yes, well, thank you very much, Maha and Darren. That was very interesting conversation. I think this webinar gives food for thought, that's for sure. So we're gonna be on time a little bit, but we have time for some questions. So the first one I have here is, if a patient has diabetes type 1 for 12 years, is there a chance to have any active B cells, and how to discover that?
Can you repeat, Natalie, the last part of the question? I'm not sure I
Is there
heard.
a chance after 12 years, if I understand, is there a chance to have any active B cells, and how to...
Oh, okay. Okay, so after a few years of evolution of type 1 diabetes, there are very low chance to have some beta cells that are still secreting residual insulin, but this is something that you can test for, and you can ask your healthcare professional. We usually test for C-peptide, which is an indicator of insulin production, endogenous insulin production, but it will most likely be negative in your case if it's a type 1 diabetes, because usually within the first 10 years, the insulin secretion really negativates. So yeah, but you can still ask your healthcare professional for that.
Thank you. I have another attendee questioning about the side effects of the delaying treatments mentioned.
Okay, so one of the treatment that has been really well studied is teplizumab, and I think I'm going to talk about this one. This is a treatment that you give as an infusion for 14 days, and this is a treatment that will calm the autoimmune attack that your beta cell experience, but it will calm all of your autoimmune capacities. And so sometimes you have a drop in your lymphocytes, which are a type of cells of immune cells that are in the blood. And so this can come with infections, with a higher rate of infections, although in the different studies that have been made, this rate is low. The second side effect that is often observed is a rash, a skin rash. But all of these effects go away once the treatment has ended. So generally, the treatment is well tolerated.
Thank you for that. Another question here: what would be the best way to stay informed about the CanScreen T1D Research Consortium, its proposed pilot study, and related screening programs?
So one of the best way is to be on the Better registry, because we have a lot of information going on in that registry. So you'll be able to have this information, but you can also go on the TrialNet website or on the CanScreen T1D website, and they have a newsletter that they can that they give people very often. So yeah, those are the ways that you can have information about screening possibilities and treatments.
Maha, if I could jump in here too, JDRF or Breakthrough T1D, if you go to their website and type
Definitely.
in trials, they have a finder and you can sign up. I've done this, sign up for notifications from them about research, the clinical research, because one of the biggest barriers to the list of research that Maha gave is actually getting patients to participate. It can be a real struggle. And so if you're interested in, whether it's TrialNet or other clinical research, that's a great way to find it. I've actually been able to do a few things that merely involved sitting down and talking to someone. What you can decide what works for you and what you're interested in. But anyway, if you go to that website, as well as the Better website, and then also directly to the organizations.
Thank you both. Another person is asking herself, if you want to get screened because your parent is T1D, Do you ask your GP or get referred to an endo?
It's usually best to be referred to an endo because I don't think the general practitioners are informed enough on the matter of screening. So it's always best to have an endo's opinion on that, I would say.
Thank you. And maybe the last question here. Do you think national screening will be a reality in Canada? In your opinion, what are the best ways to do this?
I don't know if it will be a reality in the next year or 2 years because general screening really brings a lot of drawbacks, as I show in the webinar, and it's really very costly. This is one major drawback. And I'm not sure that Canada or even other countries have the resources necessary to be able to organize the logistics that comes with general screening, because the people that you screen, those that are positive, they need to have regular follow-ups with MDs, but also with psychologists, but also with nurses. And this is something that is very costly and it takes a lot of time. And so I'm not sure this is the best way to go. I'm on the team of letting it be a personal choice. I don't know if that answers your question.
I hope so. So thank you very much again for everything, answering question and all the info you gave us on that. I think we have things to think about. I invite you all to go on the Better websites to have more info on type 1 diabetes, screening, and everything. If you can also answer I'm looking for my word. The survey, sorry. It will be very helpful for everyone, for researchers, advancement and research. So that's it. I wish you a very nice evening. I thank you again, Maha and Darren, for your time.
Pleasure.
I hope to see you all soon.
Good night.
Bye.
Good night.
Bye. Good night, everyone.
Bye.